I'm Ramaswamy Govindan, a medical oncologist at Washington University School of Medicine. We'll go ahead and introduce other panelists here. Dr. Lanuti.
Yes, hi, Michael Lanuti. I'm a thoracic surgeon at the Massachusetts General Hospital in Boston and the director of thoracic oncology for our division.
My name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis.
I'm Sanjeev Bala. I'm the head of cardiothoracic imaging here at WashU in St. Louis.
I'm Dr. Ben Levy. I'm a thoracic medical oncologist from Johns Hopkins School of Medicine.
30-year-old female with multi-month history of fatigue and malaise with diffuse myotonia, myalgia, cramping, and she was found to have a type B1 thymoma that was resected to positive margins. So we'll be discussing the management of this patient in detail. In terms of history, this patient presented with 3 months history of fatigue, weakness, and grip myotonia of the hands with myalgias, muscle cramps, along with twitches. She also had right itosis and rippling of the gastrocnemius and quadriceps muscles bilaterally. And the review of systems were notable for fatigue, activity intolerance, shortness of breath, headache, vision changes, diplopia, and right leg. She was deemed to have a performance status of 1. Her past medical history is significant for morbid obesity, pilonidal cyst. She's a lifelong non-smoker and a social drinker with no history of drug abuse. She's married with no children. Her family history is significant for father who had melanoma in situ. Let's review the CT scans. Dr. Bala.
So her CT shows that there's this mass in the anterior mediastinum that, for the most part, is soft tissue with enhancement. And there's an area that's a little bit lower, attenuation centrally. It measures about 3.6 centimeters. No evidence for invasion of the adjacent pericardium or any of the fat effacement. And it looks like it's pretty much isolated to the anterior mediastinum.
Terrific. And she had a workup done, as you could imagine, and the lab studies were significant for acetylcholine receptor binding, blocking, modulating antibodies, negative for voltage-gated potassium channel antibodies. Acetylcholine esterases were normal, and the CK was three times higher than the normal limit, 670 units per liter. She underwent thymectomy, and tumor that's about 13 centimeters was resected, deemed to have lymphocyte predominant, that's B1 in the WHO category, 4.2 centimeters in greatest dimension, with a lot of necrosis, fibrosis, and one lymph node was assessed, and it was negative for cancer. It was, this final pathology stage was T3N0. And some of the intraoperative notes are worth paying attention to. The tumor was adherent to the pleura, although no pleura was identified on the resection specimen. Clinical invasion of the Friedrich nerve was noticed, but no Friedrich nerve was identified in the resection specimen. And the flow was done. It showed 75% T cell precursors, 20% mature lymphocytes, and 5% CD45 negative and debris. And this was read out consistent with thymus gland, thymoma with predominant T cell precursors, and therefore the classification of B1. And post-operatively, there was some improvement in ptosis and diplopia, but still had residual fatigue. And there was a CT scan post-operatively. Dr. Bala, do you want to comment on this?
Just to say that there was no evidence for recurrent tumor. It looks like it's a post-operative change for the most part.
Thank you. And so this comes back to this question. Often we discuss this scenario in the clinic, in the tumor boards. Here is a patient with a clinically localized thymoma, textbook presentation, resected appropriately, and had microscopic positive margins. The question really is, what should be the next step? And before we go to Dr. Robinson and Dr. Levy, I just want to hear Dr. Lanuti's thoughts on any of the points he would like to make with regard to surgical issues and thymoma.
Yeah, thanks, Dr. Govindan. So, when we're looking at patients with what appears to be a defined outer border that's favorable for resection, really the surgeon knows the best about whether there's a margin that's close. And in regards to phrenic nerve, we often come upon this where the surgeon has to decide whether there's invasiveness of the tumor into the nerve, and does it require resection, or can we peel it off the nerve and leave a positive margin? But it comes down to the surgeon really telling the tumor board about that, and particularly the radiation therapist. Again, the best thing that a thoracic surgeon can do for these tumors is a complete resection. In young patients where there is true phrenic nerve invasion, I will resect the nerve. And at the same time, we sometimes will plicate the diaphragm because of the diaphragm paralysis that occurs. I think that leaving lots of clips behind to help our radiation therapists is something that we should teach our residents to aid in adjuvant type treatments.
Can you educate us, medical oncologists, that how does that help? Or in fact, you won't know where the margin is. You would leave clips all around, I would think. But would someone be able to put that all together from the CT scans and the pathology resected specimen?
Yeah, so I think that I only leave clips behind in places that are close margins. I don't feel like clips need to be placed everywhere. And so if you leave a whole bunch of clips in the field, it's not helpful. But clips in a close margin area, I think, can be helpful.
Okay, that's helpful. Thank you. Dr. Robinson.
Yeah, I think echoing Dr. Luniti's points, the best outcomes for these patients are going to be defined by the extent of their surgical resection. And so a complete resection is important whenever possible. In the case of positive margins, while there is no randomized data suggesting the best approach for these patients with a kind of core standard baseline philosophies of leaving microscopic disease behind, there's a presumed value of adding adjuvant radiation. There's many different retrospective studies that show that it reduces the relative recurrence rate by about 50 or higher %. Generally speaking, the dose we would give would be in the 54 gray range at a standard dose in fractionation. The goal of the treatment, while the clips are very helpful for directing the absolute known area of positive margins, and I will echo Dr. Lanuti, we definitely appreciate having those clips. With modern imaging techniques and treatment planning systems, we often co-register the initial pre-treatment simulation, pre-treatment CT, and we can deform that in a way that shows us exactly where it is with the post-operative anatomy. It's not a perfect science, but with the margins that we add, it ends up covering the whole region. If there's known gross positive disease, then the clips become increasingly more important because we need to boost that to a higher dose. And without those clips, it can be very difficult. However, I think we share with the surgeons a love of internal anatomy and reviewing imaging, and that often becomes a point where we can get together and have a collaborative planning for that.
Fantastic. Thank you. Dr. Levy, do you see any role for medical therapy here?
This is a tough one, but generally no. I mean, I think most of the data we have with systemic treatment comes in the form of, as we've discussed before, potentially induction with or without radiation prior to a surgical resection. We obviously have the data in the advanced setting. We don't have a lot of data for adjuvant chemotherapy with a positive microscopic positive margin. So, the only thing that would sway me, she's very young. She's 30 years old, and the question is, should we just give her everything that we have to prevent a recurrence? I just don't think we have that data that shows that adjuvant chemotherapy, A, prevents or reduces the risk of recurrence, or B, improves survival. So I would probably not offer adjuvant chemotherapy in this case. I would certainly refer and defer to my radiation oncology colleagues for radiation, but I would probably pump the brakes on any sort of systemic treatment at this point.
Yeah, that's the same thing we do here. I don't see any particular compelling evidence. Granted, is a very young person to add chemotherapy in the situation and adding radiation. But I do want to talk a little bit about the follow-up of these patients. Thymoma and thymoma in particular is a bit of a different beast compared to many cancers we see, especially for the chest thoracic medical oncologists. Sanji, Dr. Bala, do you want to comment on the scans, what you would see typically in these patients in terms of follow-up, what you would recommend, and we also would get the opinion from others as well.
Yeah, I think that you're absolutely right, that these are really difficult to follow up because oftentimes when they represent, and if there's any disease that's progressed, it'll appear in atypical locations. And so for us, we would recommend, as we frequently do, CTs with intravenous contrast because they can be very, very helpful for depicting whether or not you're dealing with a hilar structure or you're dealing with some sort of atypical mass in the hilar region. But we've often found that the recurrences tend to be in locations that we don't expect them to be, and they can be sometimes tucked in a recess or tucked next to a vessel, which easily is overlooked on a non-contrast CT.
And also in terms of timing too, right? I like to hear other people's thoughts. And we generally we normally see patients with lung cancer for follow-up 3, 4, 5 years, and then we either send them back to the primary care physicians or don't really do yearly CT scans after 5 years typically. Whereas thymoma can recur much later. There is also one other fact about thymoma is that patients with thymoma, much like chronic lymphocytic leukemia, are at a high risk for second malignancies. They do have high risk for other malignancies, particularly the GI cancer as well as lymphoma. And this was an analysis conducted by a group looking at the SEER data published about 15, 20 years ago. And I'd like to know your thoughts, Dr. Levy.
Yeah, it's a different animal, I think, when we're looking at surveillance post-curative intent therapy. For non-small cell lung cancer, we're keen to look very early on especially for stage 3 or even stage 2 resected lung cancer. And a lot of the recurrences occur within the first 5 years or first few years. And this is juxtaposed against thymoma, where some of the data would suggest the time of recurrence median time is around 5 to 6 years. That's the median. So I tend to follow these patients with CT scans 6 months for 2 years and then annually for 5 years. But for thymoma, I will push that to 10 years. I will follow these patients up to 10 years because recurrences can be late. And as you mentioned, Dr. Govindan, there are other these patients do have a significantly high risk for other cancers, including lymphoma and GI malignancy, soft tissue sarcoma. So these are the things that, for me, make it a little bit different of a surveillance strategy than for my non-small cell lung cancer patients.
Yeah, good. I agree. And Dr. Robinson, any thoughts?
Yeah, I guess 2 additional things to add to that. While the patterns of failure suggest that they can be late, more importantly, they are also potentially manageable. So I think, unlike other cancers where you may detect the recurrence, but it's more to tell the patient what the prognosis is, there would appear to be pretty compelling single institution or multi-institutional studies suggesting that aggressive re-resection of, say, pleural failures or otherwise could lead to prolonged survival in this patient population. And, to that note of prolonged survival, this patient's age and sex also mean that the discussions that we have as a radiation oncologist, unlike an 80-year-old with a locally advanced lung cancer, do center around things like second malignancies, even from radiation as well, cardiotoxicity, pulmonary toxicity. And so we often consider using more advanced radiation modalities such as protons for these patients as well.
Terrific. Thank you. One other thing I've seen now and then is these patients also have a high risk for low immunoglobulins. So I've had patients who had hypogammaglobulinemia, and they are at high risk for infection. So we got to keep that in mind. I think that about 10% of those patients have low IgG, and so it's worth keeping those things in mind. It's a very interesting problem to deal with. Wonderful. Thank you so much for the great discussion.
If I may, Dr. Govindan, just one more point that we've been sort of pushing, that is, in patients with resected thymic neoplasms, we intertwine MRI chest. It really does pick up pleural metastases, and I'm curious to know if Dr. Bala agrees. It really brings your eyes to the pleural mets much more so than a CT chest.
It's a great point. Dr. Bala?
Well, I would agree that in a practice where MR is routinely performed, MR can be very, very useful, but it does require a certain degree of three-dimensional techniques. The post-contrast images using a 3D post-contrast MR technique can be very helpful. A bad MR can be equally as deceiving if you're not in a center that has a lot of practice doing it. What we have found in our practice is that using multi-detector CT with routine reconstructions of 1 millimeter with multiplanar reconstructions can be equally as effective. But I think that it's key that you have thin sections and good quality images. And if it's MR, MR is a little bit better, but it has to be good quality MR.
So on that note, I have a question for Dr. Lanuti. So what if you find, let's say, a 5 millimeter pleural nodule or 8 millimeter pleural nodule? Would you go and resect it?
So I think that if we see that, oftentimes I will give some more time to see sort of the biology of the drop metastases, if you will. And I don't rush in. I think we should have some patience there. And then as you get evolution of some pleural mets, as we all know, this disease can be slow if it's not thymic carcinoma. Then at some point you could go back in, and as Dr. Robinson mentioned, local therapy, and this is really a surgical disease for us. That is, pleural mets are very amenable to surgical resection. But I don't think it's that we had to rush into it. You can sort of idle a little bit and observe for even up to a year.
Good. Thank you so much. Great discussion again.